Good morning, everyone. I'd like to welcome everybody to Winnipeg and to the Children's Hospital Research Institute of Manitoba, and who gratefully is hosting this. I'd like to welcome all the special guest speakers, Dr. Allan Goldstein, Cindy Holland, Lisa Wilson, Dr. Belinda Dickie, and of course the Shit Happens campaign founder, Liz Crawford. And on behalf of our center here and REACH, I'd like to welcome everybody. I'd also like to welcome everybody to the YouTube live stream. I've never done something live on YouTube, so that's exciting. And I just want to mention that everybody's welcome to get some more food in between if necessary, and that we want to keep the questions till the end when we have the panel discussion. And then I would like to first introduce the first speaker, Dr. Allan Goldstein. Dr. Goldstein trained at Harvard Medical School and then did a general surgery residency at the Massachusetts General Hospital. And then he went to New York to complete his fellowship in pediatric surgery, and he is specialized, has a special interest in Hirschsprung's disease. He has an active laboratory group that is studying Hirschsprung's disease in the lab, and he's going to talk about the long-term outcomes and management of Hirschsprung's disease patients. Welcome.
We'll see if that works. Thanks a lot, Richard, for the introduction, and thanks to Liz and Kate and Richard for the invitation to be here. We'll go to the beginning. That's usually the best way to start. I'm going backwards. Can you get... Let's see. We'll do this the right way. Will that work? That'll work. All right, great. It's a little bit out of order. You would think we'd hear about the earlier Hirschsprung stuff before you learn about the long-term outcomes, but it's all related to my flight schedule today. So this is what we know about Hirschsprung's basically. It's, the newborns, most typically the disease presents in newborns. 90% of the time a newborn fails to pass their first stool. The doctor thinks about Hirschsprung's disease. They get a contrast enema and do a biopsy of the rectum. We find no nerve cells in the rectum, and that tells us the kid has Hirschsprung's disease and needs a pull-through operation. So it seems very straightforward. But here's the problem. If Hirschsprung's disease is due to the absence of nerve cells in a part of the colon, then removing that colon should simply cure the disease. But it often doesn't. So why do kids continue to have a problem if we're so smart? We know what the disease is, we fix it, and yet symposia like this prove that there's still a lot of issues to address. Children with Hirschsprung's most of the time have an issue. Up to 60% will have what we call obstructive symptoms, which is basically really bad constipation with distension, inability to pass stool, the need for rectal irrigations despite having had a good operation. A variable number, 10 to 75%, will have fecal incontinence. The numbers are broad like that. Some say 10%, some say 75%, because nobody really knows how to define fecal incontinence. Is it an accident once a month? Is it actual stooling without control every day? There's a wide variety, and these studies do a bad job of really defining it, so that's why the numbers have a large range. Enterocolitis, which everybody who has Hirschsprung's disease should be aware of, where kids get explosive diarrhea, abdominal distension, sometimes fever, vomiting, lethargy. That can happen in up to 40% of kids before their pull-through and even after their pull-through. In fact, the incidence doesn't go down after their pull-through surgery. So it really goes to show that we don't know a lot about this disease. And all of these issues have a major impact on quality of life. I mean, a kid who's having accidents and at school, that's an issue for the quality of life of the patient and for the family. So why is it that these things happen? So first, a little bit about the studies that have shown that these are ongoing problems. This was a study published 5 years ago, and they looked at kids who had a pull-through for Hirschsprung's when they were babies, and then how are they doing when they're adolescents. So in this case, you can ignore all the numbers. We'll just focus on the ones on the right. But, uh-oh. So we'll keep them both up. So here's they're 8 to 16 years of age now. Don't touch the screen. That's a warning for everybody else. So they're 8 to 16 years of age now, and if you look at the upper right box, optimal outcome means they're basically the same as kids without Hirschsprung's disease. No accidents, just no constipation, no ileostomy or colostomy. Even after 8 to 16 years, only about half of them have that optimal outcome. And then the second part of this study looked at them when they're adults. So this is a review of 4 papers. They took children who had had their pull-through surgery as babies for Hirschsprung's disease, and now they're anywhere from 20 years old to 43 years old. Again, only about half of them have this optimal outcome. So we know that there's an issue long-term. And it's important to know there's an issue, not to get depressed about it, but just to know that here's a problem that we need to fix. And we can fix it. We can definitely make this better. The good news is that a lot of studies now show that the problem definitely exists but gets better as the child gets older. This was a big study published 10 years ago of 178 children with Hirschsprung's disease, and they looked specifically at fecal incontinence. And if you look, there's 3 groups. Group A is 5 to 10 years after surgery. Group B, these are kids 10 to 15 years after surgery. And Group C is 15 to 20 years after their operation. At the beginning, early on after surgery, only 58% have this excellent result. Excellent result means that they were having, like maybe they'd have an accident once a week. It wasn't affecting their social life. They were totally functional. 7.5%, this is 5 to 10 years after surgery, the average age of almost 9 years. 7.5% had a fair result. They were nice to call it fair. It was a poor result. They were having accidents every day. That's not so wonderful, except when you notice that as they got older and further from their operation, almost 90% are doing great. Nobody's doing poorly at this time point. So that's, we should be hopeful that even if you did basically very little to change things, it improves over time. This other study, I think it's the last one I'll talk about, is 57 patients who had a transanal pull-through for Hirschsprung's disease. The transanal operation, where the whole operation is done from below, started about 20 years ago, so now we have more long-term data. This was just published this year. Most of them were male. In Hirschsprung's disease, it's 4 to 1 male to female, and 80% are short segment, so this is about the average that we see. And then this is 15 years later, and they compared it to 171 kids who did not have Hirschsprung's disease. Social continence is defined many different ways. In general, social continence is what we strive for after colorectal surgery. It means that you have no significant accidents. You function normally in a social setting. You're not afraid of having a soiling. Even if it requires medicines, that's fine, as long as you can achieve this goal of being comfortable in a social setting with minimal fecal issues. If you looked at all these 57 patients, 2/3 of them had fecal soiling, and 1/3 of them had fecal accidents. Accidents are larger than soilings. But again, if you looked 4 to 12 years of age, 13 to 17 years of age, and then as young adults, green is the control group, right? They do really well. They have a score of 19 or 20 on this bowel function score, which is, it's a measure of 7 different types of things like constipation, soiling, accidents, social, issues, quality of life. That's what the green ones are, what we want to achieve. That's the sort of the best you can do. But see, the 4 to 12-year-olds, not so good in their scores, but again, got better as they got older. So we can talk a little later about why is it the kids get better, but more importantly, we need to focus on the ones that are younger. They're not doing that well. What do we need to do to get them better faster? In this same study, they looked at fecal accidents, and you can see that early on, 60% of kids will have a fecal accident. 13 to 17-year-olds, much less. And by the time they're young adults again, they're no different than their peers. But kids who have a pull-through for Hirschsprung's disease have more frequent bowel movements. The blue are the kids with Hirschsprung's, red are the ones that are the control group. And you can see that overall, the blue group, the Hirschsprung's group, has 5 bowel movements per day. That's their average, and that does not change over time. That's related to removing part of the colon, specifically the rectum, and we'll discuss that more. And then there's this quality of life issue. It's not all about, quality of life is tightly tied into how we function, our bowel movements function. People that have fecal incontinence in general have a hard time in social settings and similar issues. This was very interesting, though, and has been shown by other people in other diseases as well. Children with Hirschsprung's report normal quality of life, even though they have issues with fecal control. In fact, their scores on emotional scales and social scales are better than kids without Hirschsprung's disease. And that goes very well with what other psychologists have shown, that children who have a chronic illness have better coping strategies than children without. That probably doesn't come as a surprise to most of us. It was nice to see that held up in this study. Parents, on the other hand, are different. Parents scored lower than the children for sadness and depression. And that, if you have children, that is no surprise. We live just pure anxiety all day about how our children are doing. You're only as happy as your least happy child. But we don't even know if our kids are happy. We just assume, oh, he's having an accident, life's miserable, I'm miserable. So parents' anxiety is much more than the child. Parents' quality of life is lower than the child's self-reported quality of life. I think this is important to know because it's hard to deny the fact that parents, the whole family, needs psychological support when you're dealing with any chronic illness, and Hirschsprung's disease is no different. So now let's talk about the problems. We'll skip enterocolitis. It's a whole topic on itself, but more the obstructive symptoms and the fecal incontinence. Why do they happen? We'll go through this relatively quickly. Obstructive symptoms, we think of 5 causes. This is the typical example. This is an 18-month-old boy that I saw has Hirschsprung's and Down syndrome, right? 10% of kids with Hirschsprung's have Down syndrome. He was diagnosed as a newborn. He did fine. He had the usual pull-through at 1 month of age. Does great. Most surgeons stop seeing him. So as far as we're concerned, great operation. But if you bother to see him long-term, you'll learn more about how they don't do well. And this kid, at 18 months of age, got this distended and started having vomiting. So that's typical obstructive symptoms. For the surgeons in the room, they'll recognize the mechanical causes. We love mechanical causes of anything because that's something you can fix easily, whether it's because the pull-through, if you notice on this contrast enema, is twisted, or if you're doing a suave operation and the muscular cuff that's left behind is too long or too tight, or simply because there's a stricture at the coloanal anastomosis. So these are things that can be fixed surgically and need to be thought about, and emphasize the importance in obstructive symptoms of a good rectal exam and a contrast enema. Then we get to more complicated things to fix. What if the part of the colon we pull down is not normal? So in Hirschsprung's disease, there's no nerve cells. The black dots are nerve cells. There's none in the aganglionic segment. And somewhere in the rest of the colon, maybe there's normal. But what about in between? This is the region we call the transition zone. Do we pull down this part because the pathologist told us there's a nerve cell there? Or is it just not enough nerve cells and we really should be pulling down this part of the colon? So the presence of no ganglion cells in the pull-through is a problem. If you pull down only up to here, you bring this part of the colon to the anus, that may be a problem. Too few, or maybe up here they're just not normal. There's plenty of them, but they don't work right. So these are called transition zone pull-throughs, and they're a cause of obstructive symptoms. The other problem is important to remember that Hirschsprung's disease isn't just the lack of nerve cells in the colon. There's this whole issue with the anal sphincter. So normally, when stool reaches the rectum stretches, it knows there's stool, and there's a reflex that the full rectum relaxes the anal sphincter. That doesn't happen in Hirschsprung's disease. So in Hirschsprung's disease, the sphincter doesn't relax. This is a balloon test, an anorectal manometry that can be done to look for this. If you blow up a balloon in the rectum, the pressure in the sphincter should drop every time you blow up that balloon. But in Hirschsprung's, it doesn't do that. And sometimes this can be the cause of obstructive symptoms, just the fact that it doesn't relax or the fact that the sphincter may be too tight. Botox is a common treatment for that, or actually cutting the sphincter can be done as well. And then the fourth thing, these get more complicated as we go. This is a challenging problem. This is a kid who had a pull-through for Hirschsprung's. Everything went great, but now his colon is huge and not working. Even after a good pull-through, We don't know anything about the colon that's left behind, except that it has nerve cells, because that's the extent of our knowledge. That's all our pathologists can tell us is yes, there's nerve cells, or no, there's no nerve cells. It'd be like a neurologist only be able to tell you, look, your baby definitely has a brain or no brain. So we're very not sophisticated here when it comes to understanding Hirschsprung's disease. So they can have their operation, the colon doesn't work. Now, we really don't know why. I think a common reason is probably that the nerves are present but are not normal. But there's other cells that are very important. It's just not about only nerves. There's muscle that's required for squeezing the colon. And between nerves and muscles, there's these cells of Cajal. These are all, we can't do anything about these things, nor can we relieve and diagnose these problems. It's just important to recognize that if there's no mechanical obstruction, if the sphincter's not the problem, and if there's no transition zone pull through, think about the fact that the rest of the colon may have nerve cells, but just not work right. And we'll talk later about antegrade enemas or bowel management as a way of treating this. And finally, there's functional constipation. Children who live an early life of rectal anal surgery, dilations, irrigations, rectal exams, can develop this withholding behavior. They start to associate that part of the body and stooling with pain. And children simply are very stubborn and make up their mind, I know, I'll just stop stooling. And they really amazingly can do that. They have very strong external sphincters. They have strong buttocks. You'll see them stand and withhold. And this is something that can happen and can be a cause of real obstruction. This is why most of the groups that take care of a lot of kids with colorectal problems have a child psychologist or psychiatrist as part of the team. We're not going to go through this, except that we use a very, sort of a real algorithm. You have obstructive symptoms. Okay, it's like just a simple menu. We're going to do this. We're going to do a rectal exam and a contrast enema. If those are okay, we're going to do a rectal biopsy. If that's okay, we'll do an anorectal manometry. Just step by step to make sure you figure out exactly what the problem is so we treat the actual problem. Fecal incontinence is something if you ask most pediatric surgeons 10 years ago, I think they would have said, yeah, that doesn't seem to happen much after this operation. But over the last mostly 5 to 8 years, there's been a lot of papers, and it's clear that half of children with Hirschsprung's disease will have fecal incontinence. And that, as I said, has a big impact on quality of life. We have schools around where we are that don't even let kids go to school if they have significant incontinence, mostly up in parts of Maine and other parts of the state, not so much in Boston. Again, it improves with age, but clearly some continue to soil into adulthood. So when we think about fecal incontinence, it's important to distinguish true incontinence. That's this situation, which is just here's the colon, it looks fine, just the stool comes out uncontrolled. As opposed to what we call pseudo-incontinence, which is just bad constipation. This colon is full of stool. And the reason this kid is having accidents is just overflow. The stool can't come out, so it just leaks out intermittently. So that distinction, we see a kid having accidents, don't assume it's fecal incontinence. It could, in fact, be that the kid's horribly constipated. But if it's true incontinence, we have to think about, well, why might that be? So fecal control basically requires 3 things. You have to have a colon and a rectum that squeeze well. You have to have normal sensation. The rectum has to know when there's stool in it, and the anal canal has to know also be able to sense that there's stool present and ready to come out. And the sphincters, we call the doors, have to work. There's a sphincter we can't control. That's that internal anal sphincter. That's the one that's supposed to relax by itself when there's stool in the rectum. And then the external sphincter is the one we say not at a bathroom yet, so we squeeze the external sphincter until we're ready to relax it. Those sphincters have to function normally. So once we know what controls fecal continence, we can think about the things that cause incontinence. First, Hirschsprung's disease is a development problem. The colon, the rectum just didn't develop right. So maybe it's not just the nerves in the colon, maybe it also involves abnormal development of the muscles and the nerves that control the sphincters and the rectum. Maybe the colon's squeezing too fast and it's just beyond the control of the child. And that definitely happens, we'll talk about that. The other thing is the rectum's gone after a pull-through. In every pull-through operation, the rectum is removed because that's always involved in Hirschsprung's. So the rectum is a very important job. It's a reservoir. It sits just above the anus to store stool. And if it's absent, there's nowhere to store stool. The other problem with the rectum being gone is that the contractions that squeeze the colon stop before they get to the rectum, right? The contractions don't go all the way to the anus. That'd be bad. You'd have to have a bucket like a horse on the, but so the contractions stop at the rectum. Then you get rid of the rectum, now the contractions go all the way down right to the anus. So losing the rectum is a big deal. Maybe the sensation in the rectum isn't normal. The rectum, there's nerves control muscle. We always think of the nerves that are missing in Hirschsprung's as the ones that control the peristalsis, the squeezing of the colon. They're the same nerves that, well, the nerves right that are also missing control sensation. So now the rectum, the colon doesn't really have good sensation. And after a pull through, we don't know that the nerves that are left behind either can sense as well as they should. It's possible that the anal sphincters don't work well, and certainly surgeons, other than me and Belinda and Richard, other surgeons might be injuring the sphincters or the nerves. So the first question we have to ask are the rectum and the anus doing their job? Does the rectum squeeze? Can the patient sense the need that stool is present and he has the need to pass stool? And do the sphincters close and open as needed? We talked about the causes. We like to do anorectal manometry, which is where you put a probe. This is a three-dimensional, high-definition probe. You can put it in the rectum. Most children will tolerate this awake, and sometimes they have to be asleep, but it's not as useful a test. And here they're being asked, the kid will like squeeze, bear down, pretend he's having a bowel movement, and these pictures give us a three-dimensional impression of what the rectal canal, the anal canal looks like and where the pressures are and is everything working right. Also, you can blow up a balloon in the rectum and ask the kid to push it out. You can ask him when he feels the balloon. So this I find to be a helpful test when you're trying to work out why incontinence is happening. I don't know how much it guides therapy. I think it's interesting to know what the cause of the problem is, and it's good to figure out where the issues are. It can be helpful for our physical therapists. We have a good team of pelvic physical therapists. These are hard to find pediatric therapists or physical therapists who have experience with teaching children how to have bowel movements, but there's some good ones in the Boston area, which we're lucky to have. And having that information helps to guide exactly what aspect of defecation they need to work on. But most of these kids just end up going down the bowel management path, which is rectal enemas or antegrade enemas, which we'll talk about. That's the appendicostomy thing, just to control their bowel movements. The second question we have to ask is the colon moving too fast? It may be that the rectum and the anus are working fine or not, but the colon has to contract in an organized way, in a certain frequency, and again, not all the way down to the anus. So after a pull-through, as I mentioned, the rectum is gone. So first, there's nowhere for stool to be stored. Second, the colonic contractions move all the way to the bottom. And third, anytime we operate on the colon or the rectum, we know that there's an increase in the number of contractions and how fast they come. That threefold combination of things is really a problem and probably explains why 50% of kids continue to have some type of accidents as they get older. So the colonic hypermotility, we can assume it's happening in about half the kids. Some don't have any colonic contractions, by the way, after their pull-through. So they don't have hypermotility, they have hypomotility. And they usually end up having that pseudo-incontinence, the really bad constipation and the accidents. The other half have been shown to have hypermotility and too many contractions. In that population, we use Imodium a lot, loperamide. You can use fiber to bulk the stool. Psyllium is Metamucil, dextrin is Benefiber. These are all soluble fibers that bulk the stool by drawing more water in, making it larger and easier to sense and easier to control. Amitriptyline is an interesting drug. It's used mostly by psychiatrists, but it can decrease the frequency of contractions of the colon, and so it can be helpful here too. Enemas are very helpful, whether they're rectal or antegrade. We'll talk about the antegrade enemas in a minute. And of course, making sure, like any kid with constipation or stooling issues, making sure you have a nice regimen for, you eat and then you sit down for a period of time with your iPhone, with the television, whatever, just getting them into a pattern of behavior that's consistent. We shouldn't assume that just because they have Hirschsprung's disease, their incontinence has to be due to Hirschsprung's disease and their pull-through operation. They're still regular kids. They can have lactose intolerance and food allergies and inflammatory bowel disease. So we have to always consider the other possibilities and not just be too narrow focused that it must be Hirschsprung's related. Snacking should be avoided. Snacking, every time you eat, you stimulate a colonic contraction. It's the gastrocolic reflex. Every time the stomach gets food, it sends a signal to the colon to contract. So snacking can contribute to the problem. And I think it's helpful to make one change at a time. If you're changing diet or you're changing anything, keep a journal, see how that affects frequency of bowel movements, accidents, all that, and then don't make another change until you're ready a few days later. Otherwise, you'll never know what really helped. We give families these sort of guidelines on what to eat. They should avoid foods that are laxative foods, and they should encourage foods that are more constipating. And you can, maybe you guys already have this kind of list here, or otherwise we can send it around. But fatty foods definitely are laxative foods, dairy foods, fried foods, as opposed to things that are more constipating, rice, white rice, white bread, white pastas, and some meat, chicken and fish are good, as long as they're not fried. So sometimes we get through all of this, and the fact remains that you have a kid who has fecal accidents, and we need to treat them. And I find this to be a very helpful way to treat them. It's the antegrade enemas. Antegrade enemas, if you picture it here, is basically there's a little access to the large intestine, whether it's through this appendix, which isn't in this picture. Oh, it is right here. Appendix, or directly into the cecum, which is the first part of the large intestine. And then you just pour in fluid, laxative fluid. They sit on the toilet and it empties their colon. And it's one treatment for both severe constipation, because it cleans out the colon, and for incontinence, because it cleans out the colon, and it keeps it clean until the next day. Some surgeons feel that you have to prove first that rectal enemas are an effective approach, that if rectal enemas work, then you can move to antegrade enemas. So you don't have to go through the bottom, you can go through these, directly into the colon. I'm not sure that that's really true, but that's a reasonable approach. Just confirm that enemas are effective and then start using this. So I think retrograde enemas, which are your traditional enemas, are fine if the child can tolerate it, but that can be hard as the kid gets a little older, and it's hard on families as well to do that. So I find that antegrade enemas are just a much easier way to administer the flush. They empty the colon, they decrease the need for laxatives, and they seem to be very effective. There's two basic approaches. One is the cecostomy. We use these little G2 buttons, or the Chait button, which was designed in Toronto. Put that right into the cecum, and that's a day, a same day operation most of the time. Little children will go home the next day, and this is what it's like. They just plug in their fluid, and we'll talk about what's in this bag, and sit on the toilet an average of 20 to 45 minutes. The appendicostomy is just a little bit more surgery, but also kids can go home the same day, if not the next day, where the appendix is opened. It's sewn a certain way so that poop just doesn't come leaking out the end of the appendix, but you sew it up here, bring it out the belly button, and then a kid or a parent can put a catheter into the appendix through the belly button every day to clean out the colon. We tend to use this for the flush, about 300 ml to a liter of water, and this can be just tap water, depending on the size of the patient. And we add PEG, which is Miralax. You guys have Restoralax. And they're all polyethylene glycol. Or Golightly is the same thing. Golightly is essentially PEG in water. Either one is fine. If that's not enough to clean out their colon, we add Bisacodyl, which is Ducolax. If that's not enough, we add mineral oil. Everybody's a little different. We find that we have to adjust things for about a month. The first month, the parents are in constant contact till we get the right amount of liquid with the right composition so that they have an effective evacuation within 45 minutes every day on the toilet. And it really can improve. If you can get rid of accidents, you can significantly improve quality of life. What time do I have till? Okay, I'm almost done. Well, I just wanted to say that there, it's, I think, frustrating often for parents that that the surgery is not exactly curative. It can be. Many kids do great, and you really don't hear from them again after their pull-through. But the majority have issues. So I just wanted to talk a minute about what the future might hold for, it would be my grandchildren, many of your children. And that's the idea of transplanting nerve cells back into the colon. Right now, the concept is this, that we can isolate autologous cells, which means a patient's own cells, from their intestine and isolate out the nerve cells. We call them stem cells. These are nerve cells that can become any type of nerve. There's like 20 different types of nerve cells in the colon. So we can isolate, take a little piece of the intestine that has nerve cells, isolate the nerve cells out of it, grow them up in a dish, and give them back to the child wherever their nerve cells aren't working or are missing. We do this right now in mice, and we can take the intestine. We use the outer layer of the intestine, which has the richest source of nerve cells, grow them up in a dish, and then they actually turn into these beautiful green balls of nerve cells. These are rich, just like almost 80–90% just nerve stem cells. And if we look at them, we can cut those balls and see what kinds of proteins are present. And these are all the types of proteins that we expect to see for a nerve stem cell, neuronal stem cell. And if we let them become nerves in a dish, they look and act, they function like nerves. So we know that we can really isolate and grow stem cells from the intestine's nerves. And we can do it, we do it with human tissue a lot as well, and it's very effective. Then what do we do with those nerve cells? The idea, at least in the mice, what we do is we inject those cells into the rectum. And then those cells are right here. This is a normal mouse, and these are his normal nerve cells in green, and these are the cells we delivered. Very disorganized. We know that the nerve cell, all the right nerve cells are present, and they are able to divide and proliferate and grow, but we don't know yet if they can actually improve gut function. We do this with mice that have Hirschsprung's disease, and that's the model. We're trying to see whether, in fact, we can recover intestinal function in those animals. This is entirely animal research at this point. There's not ready for prime time. But we think over the next 5 years, we can really get better at isolating the nerve cells, growing them right, making the right proportions of the right types of nerve cells. We don't want just one type, that wouldn't work. We need the right amount of the right types of nerves present. Within 5 years, I think not only will we be transplanting those into animals with Hirschsprung's disease and actually demonstrating improved function, but ultimately starting clinical trials. And I think that time window is reasonable for starting clinical trials in other diseases. Hirschsprung is going to be a hard one because these are babies. Very hard to do that kind of research right off the bat on babies. There are many other diseases that have to do with the nerves of the intestine, and so there's some good diseases that are perfect candidates for this research in adults first. We'd rather practice on adults before children. So anyway, that's all I have, and I won't be here later for the questions and answers, unfortunately, but Dr. Dickie can answer everything. She is really outstanding, so I'll leave it at that.
So maybe we should, sorry.
Thanks.
If it's okay, maybe we can do a few questions for Dr. Goldstein at this point because he's leaving later. Or any? Okay.
Oh,
You got lots of time.
we can tell you whatever you want to know.
Any questions from the audience?
In your mouse model, when you're growing the cells, what issues do you have with the axons, dendrites, connections, and all this and that?
Yeah, it's interesting.
We have to repeat the question.
I'm going to repeat the question. So when we isolate the cells from the nerve cells from the mouse, the question was, do we have any issues with the axons and dendrites and all of that stuff? So axons and dendrites are the fibers that come into the cell body and then the fibers that leave the cell body. When we look at so nerve cells are in the gut are a little bit different than in other parts of the peripheral nervous system. For example, they're not myelinated, the nerves, And so we look specifically, not at so much at that question, but at what neurotransmitters are present, and do they release the neurotransmitter, and do they activate calcium signals which is necessary to send action potentials. We think that so again, the intestine has all of the same nerve types that the spinal cord and brain have. It's at least 20 different types of nerve cells, and what makes them different is the type of signals they secrete, the molecules they secrete. Some nerves are intended to be what we call excitatory. They squeeze the intestine, and some are inhibitory. They relax the intestine. You can't have only the ones that squeeze the intestine or the ones that only relax, so we need the right mix of both. In terms of, just to get a little bit off, because I can't answer your question exactly, but in general, we have all of the neuronal subtypes present. The proportions, we don't know what normal is as part of the challenge, so I can't tell you if they're in the right proportions. They definitely activate calcium signaling, and they communicate with each other. So when one nerve cell activates calcium, and we do this with GCAMP, which is a calcium indicator of calcium activity. We know that one nerve cell, when it activates, we'll see its neighbor activated, and we'll see like a sequence of activity. That suggests, to your point, that there is some sort of proper neurofiber connection from cell to cell. So that's the extent that we can say right now. Now, it's even more complicated in the gut because there's no real neuromuscular plate. We don't know how the nerves activate the muscle cells. It's not like skeletal muscle. So we don't know where those fibers don't actually have to, there's no growth, like they don't hit, there's no neuromuscular junction. They sort of like secrete their signal, and somehow the surrounding smooth muscle detects it and squeezes. So your question's very important, and I wish we could, but hopefully over the next couple of years we'll have answers. Great. I'll be right in the lab waiting. Yeah. Yeah.
One is this research for existing patients as well, or just new prior to pull through, and what would that do? And the second one, is there any study on the pull-through surgery, 4 weeks you mentioned in the presentation, or waiting longer? Is there some consensus of when is the best
To do the operation. All right, so I'll answer that one first. The question is, when is the right time to do pull-through surgery? And I'm going to answer that by letting Dr. Dickie answer that. And I don't know, are you going to talk about that in your talk? What's that? Not really. Bummer. Well, it has to be so that's but they're both very good questions. That one, I mean, you could ask 3 different surgeons and get 3 different opinions. Let's talk about short segment Hirschsprungs. We will get no consensus when it comes to total colonic Hirschsprungs. In short segment Hirschsprungs, we make the diagnosis, assuming we do as a newborn in the NICU. We like to let them go home if we can get the colon evacuating with rectal dilations or irrigations, and bring them back within 1 to 2 months for a laparoscopic transanal pull-through operation. Do you have an alternative that you like?
We'll do them as newborns. So I think it depends on surgeon comfort
Mm-hmm.
and what they're used to. So there's some people who do them as newborns, so as they're diagnosed, they can help do the surgery and go home. Or it depends on scheduling and all that sort
Yeah.
of stuff. And if you can control them with medications,
All right.
no study on,
So, there's...
is there any data that
Yeah, there's very mediocre data, and I mean, recently there was a paper from China that compared how they did, and they felt strongly to wait. The kids did better if you waited longer, but just because there's a study doesn't mean there's good data. And so I would say in general, there's no good data. It's very hard to get robust studies in Hirschsprung's disease just because there's no, you really have to randomize it and do it the same way every time. You can't compare the 3 of our results because we each do something different, and so that would make a terrible study. Richard, what do you do? A newborn diagnosed with Hirschsprung's disease?
I tend to wait a little bit.
Okay.
Just also because of scheduling issue.
Yeah, I like them to be a little bit bigger. They grow awfully quick when they're little, so.
Easier than to when
Yeah.
it's a little bit more
Cindy?
grown.
I was just gonna say, I think when I look at our surgeons here, they all seem to wait maybe 3 to 6 months at the
Mhm.
latest, because although it varies maybe between centers and surgeons, I think most might agree that they'd like to get it done before the baby starts Pavlov rice cereal
Cereal, yeah.
foods, where the stool then becomes thick and sticky. So that might be a bit of a consensus
Yep.
before the food is progressed.
Yeah, I guess we could agree then to do it within the first several months of life. That would probably cover all of us. So your other question is very good. The cell therapy transplants, is that for when they're first diagnosed or when they're older? So in general, I think that it's probably when they're older. When you're, yeah, because when you're first diagnosed, you have like maybe this much intestine with no nerve cells. When you look at a mouse, that's like nothing. In a human, that's a lot of intestine that we would have to deliver millions of cells to and have it organized in the right way and make the right connections with each other and with the muscle. And that's probably, that's a dream that may be beyond, reality. In contrast, after the pull-through, so we don't want to put surgeons out of business, God forbid, and so you can do the pull-through surgery, and if they're still having issues, deliver nerve cells to supplement the ones that are either not working normally or that are not enough numbers, something like that. It's hard to know exactly what the right answer is, but I think it's more likely after pull-through surgery for the ones who aren't doing great. Richard.
I was glad to hear, and that's my experience too, you had a bit of a positive message in the beginning. Because it's so frustrating doing the surgery and then
Mm-hmm.
struggle so long, but they seem to tend to be better later in life. Is there any idea how this works and what's behind it, why they seem to improve when they grow older?
Yeah, that's a great question. Why do kids seem to do better as they get older? For example, enterocolitis, which is a horrible problem, seems to stop when the kid hits school. I don't know what their teachers teach them, but they're brilliant because I rarely see a school-age child have enterocolitis. We have no idea why that is. And the incontinence improves too as they get older. So it is possible that children, a couple of things. First, they evacuate better, I think, as you get older and get stronger abdominal musculature and improved dynamics of defecation. Secondly, they may learn to read their body better, and so to know, oh, I have the sensation I have to stool now. They learn it differently than sort of we're born to learn it, because they probably don't feel the same sensation in the rectum. We were talking last night, maybe they feel some cramping. They learn to associate this feeling with the need to stool, and then they stool. I think those are some potential reasons. They also probably, as they get older, figure out what foods work and what foods don't, and so they avoid the ones that make them have accidents. And so, yeah, thank God they're smart, and so they figure it out. We would like them to get better much quicker. Like to wait till a kid's 15, that's not so nice. That we've got to do better. So I think just an awareness of the risk of incontinence leads. If we could broaden that message beyond big academic centers where I think we know the message. It would just prompt people to get attention sooner. Don't accept the answer from your pediatric surgeon or gastroenterologist that you have Hirschsprung's, you're going to have accidents, can't help you. No, that's unacceptable. Of course we can help, and there's plenty of things we can try to help. Are we going to fix it every time? No, but sometimes we'll make at least a difference. It's a big difference having an accident twice a day or having an accident twice a week. I mean, that's a lifestyle, huge quality of life difference. Great, thanks.
Safe travels. I just realized that I didn't mention my own name. My name is Richard Keijzer, and I'm a pediatric surgeon here at the Children's Hospital. And I got to work with Liz on the Shit Happens campaign when we did some social media studies. And that learned me a lot about social media. Anyway, so we move on to the next speaker, Cindy Holland, who is our surgical nurse practitioner in the Children's Hospital. And she's kind of our mouth when we're operating or doing other things, and she talks to the parents and to the patients a lot, so she's a great help for our practice. And she's going to talk about the bowel management program that we've developed here.
All right. Are we going to bring up the presentation? Oh, okay. It's on the desktop. Well, thank you for inviting me to
Which one is
speak.
yours?
It's the HD Symposium at the bottom there. Yeah. And as Dr. Keijzer said, I work with our 7 pediatric surgeons, so that's always fun. Everyone sometimes has a little differing opinion. Although I work with a lot of various things because I'm the only nurse practitioner with pediatric surgery, I do have a passion for Hirschsprung's, as I think some of my audience would attest to. So much that I've actually been nicknamed the Poop Queen. because, you know, I think it's a really interesting topic, and it just shows from everything that Dr. Goldstein has said that these families need ongoing support. So it's nice to have that consistent go-to. Oops. So I know there's a lot of information there. I will echo Dr. Goldstein's lecture somewhat, so do a little Zen review, Hirschsprung's, but I don't need to elaborate on that. I'll show you the definitive barium enema, as we say, that we do as part of the diagnosis. We'll talk about the survey that we had done with the help of Liz and the Hirschsprung's community to show that what people are saying are the problems with bowel management and what the kids with constipation and all those abdominal issues actually have. We'll try and touch on the literature review. We tried to look at, looking at these top issues, what is out there in the evidence to say how should we manage these things. We'll look at surgical treatment options, the non-surgical treatment options, and then try and talk a little bit more about the bowel management. So again, 1 in 5,000 births is the incidence of Hirschsprung's disease. And as Dr. Goldstein said, aganglionosis, those nerves are missing, right? The colon cannot just push that poop down. So that's resulting in the pooping or stooling difficulties. As he mentioned, diagnosis is typically rectal biopsy, the gold standard, to show if the ganglion cells are there or not. And the barium enema, to try and look at the abnormal colon compared to the normal colon and where that transition might be. And it's treated with surgery, as we all know, the pull-through. So this is the barium enema, just to give you that visual of what the colon actually looks like. The contrast is put inside the colon through a tube. And you can see the normal colon on the left there. It's a nice caliber, kind of equal throughout. Compared to the one with Hirschsprung's, you can see how that colon, from the anus going upward, is just constantly squeezed. It doesn't have the nerve cells to relax. So that's what's happening inside the body. And you can see why everything gets backed up above it. So after the pull-through, everyone says, most kids do well, right? Everyone says that. And as we've alluded to, a lot of people don't. They still have trouble stooling. So looking at our community and what Liz has access to with all her connections, we did 2 surveys that were very enlightening. We did a survey of caregivers online on the Hirschsprung's community. 89 people participated in that survey. We also surveyed the Canadian Association of Pediatric Surgeons. We had 52 surgeons from across Canada give us more information about what their top issues were. Liz's team created this beautiful picture. It's maybe a bit complex, but what it shows is that the families in the pink and the CAP surgeons on the right, their top priority was bowel management. Go figure. Along with a lot of other things we talked about, the infection, diaper rash, nutrition, pain, surgical complications, and diagnosing. Obviously, the surgeons are more interested in that. But it just goes to show you that we're all experiencing the same problems. So with the surveys, specifically, the reported bowel issues were diarrhea, stool incontinence or having accidents, lots of gassiness, excessive gassiness, foul gassiness, abdominal distension, irregular stooling, that explosive stools, constipation, toilet training problems, and also that anal sensation problem that we talked about. Unfortunately, that's me crying. When we did the literature review of those top 7 issues, including bowel management, there's so little out there. It was very unfortunate, but that again goes to show you we don't know a lot about Hirschsprung's. The research isn't there yet to try and see what these outcomes are like. How are these kids doing? How can we fix things? But I think we're on that way. So, and there was also no research at all on toilet training specific to children with Hirschsprung's. Now, what was useful is that Dr. Langer from Toronto Sick Kids did create an algorithm, so a strategic approach to managing children who are having difficulties. 10% of his population was complaining of constipation, distension, vomiting, and that enterocolitis. And of course, it goes without saying, these are resulting in multiple hospitalizations, frustration, stress, quality of living, and all that stuff. So this is just his picture of his algorithm. I know there's lots of algorithms out there, but it just shows that strategic approach, trying to figure out what the problem is and then what to do about it. So this is very useful to help people guide their practice. So his approach is a detailed assessment, that history and physical, talking in clinic, give me the details about your child, how are things going, their pooping history, etc. Doing the barium enema, like that x-ray picture, just to make sure that there's nothing mechanical, as we say, something a surgeon can fix, which they like because it's just easier. And then looking at the treatment options based on what they find in that assessment process for that child. So he had talked about surgical treatment options. Everyone who's had Hirschsprung's, a child with Hirschsprung's, will remember those Hager dilators, those metal rods that are used to insert into the anus to try and keep that anal anastomosis, or where it's sutured, to keep it from scarring down. So sometimes they need that to help stimulate the anus, because we've talked about how the anus just doesn't work well. It doesn't want to relax. So often some children can get by with using the dilator as a stimulator to open things up, the anus can relax, and that can help them stool. So that's one option. Anal Botox injection, we can relax the anus by injecting in an operating room when the child is asleep. Botox into the anal area. It's not just for your forehead. It works quite well in the anus for some children. Unfortunately, it isn't a long-term fix. It may last roughly 3 months, but some children can get by with just repeated anal Botox. There's also, of course, the redo pull-through, where they have surgery again to try and take out another segment of colon. And then we talked about the sphincterotomy, where they cut into the anus to try and open that up as well. And we talked about the cecostomy tube, or colostomy, so doing flushes through a little tube in the belly that goes into the colon. Or, you know, when it becomes just too difficult, bringing out the colon, or an ileostomy, out to the belly, and they poop into a bag. And it's more of a controlled evacuation, taking it away from the bottom, which has been giving them the problems. Non-surgical treatment options then, diet is important. It's huge. I know in Toronto, the nurse practitioner said they really start early with their education. You know, before a child is 2 and 3 and loves to eat candy and sugar and donuts. So if you can do a lot of front-end loading and educating families on what to avoid, and Lisa's going to talk about nutrition in detail, but what can they do just with diet alone? Because some kids, again, can get by with more fiber, more water, making sure that they're taking in enough of the healthy options and limiting those things or eliminating certain things that can contribute to more problems. We have the medications. Some of you have tried things such as laxatives, trying to stimulate things, or medications that slow the gut down depending what the problem is. Those are the motility agents and stool softeners, you know, such as the Restorelax. There's the rectal enemas that I'll talk about a bit more. And then there's that huge behavioral component. I had the benefit of speaking to actually a pelvic floor specialist in Winnipeg, and it was really amazing to hear that a simple thing such as a squatty potty, maybe some of you have seen them, putting a stool by the toilet so that the child, when they're sitting on the toilet, changes the angle of the pelvis when they're trying to have a poop. They put their feet up on the stool, changing the angle and making it actually much more easy and effective to evacuate. So there's some small things that we can also do to help improve the situation. So where does that leave us then? What do we do? So in regards to bowel management, I think what we have learned is that a team approach really works the best. Having something that's just organized, working as a team, a really comprehensive history, good assessment, determining exactly what the child's problem is, doing any more tests or x-rays or rectal biopsy that needs to be repeated, what have you, to find out if there is some mechanical problem that's causing your child's issues. And then having a discussion about, does your child actually need surgical intervention? Could it be a consideration, and which one of those few that we discussed? Or are there non-surgical that we can manipulate or, you know, to improve your child's situation? Or it might be a combination of both. But regardless, I think it just requires a strategic approach. So here at Children's, that's Dr. Lammen. She's one of our pediatric surgeons, and I'm kind of thing one, thing two there with her. We're creating a bowel regime program. Now, it's not as extensive and huge as, say, Cincinnati and Dr. Pena, But, we are in the early stages, but we're finding that it's been really helpful having some families participate in her bowel regime program, and she does invite other families to participate. I think for one, it does help us gather more information about how the kids are doing and creating more long-term outcome studies. So we have the benefit of being part of a grant to collect this information and create a database. So hopefully in a few years, we'll have more real information about how kids truly are doing and what are they doing to make things better. So it'd be nice to have some literature. But in regards to her program, what she does is that she invites you to come to her clinic, again, sit down and have a very good conversation about the details of your child. Are they having the accidents? How often do they poop? What is their diet like? She has a very detailed survey that she asks all these organized questions. She then does x-rays or tests, barium enema, puts the child to sleep just to assess the anus to make sure it's intact. Some things to make sure that there isn't, again, something surgical or mechanical contributing to the problem. That barium enema is very useful to outline the colon after a pull-through, because we had mentioned that what if there's constipation and you're getting overflow? Well, you're going to see that huge, floppy, distended colon, right? Versus a normal colon, maybe it's not huge and floppy, but they're still having issues. And that helps her guide her little algorithm on what to do with these children. So her treatment, diet, huge. We have some good conversations about improving and optimizing their diet, limiting things that Lisa will talk about. One arm might be medications. There's some children who will do well with just doing laxatives, maybe Dulcolax every night. So there's a bit of a trial and error. We're using a poop diary, daily communication to try and work with that family to see what medication for that child works the best, because we never know when you take a pill when it's going to react, or when you drink your 8 ounces of Restorelax, you don't know the timing of that defecation. So it's a bit of a trial and error in keeping a poop diary, a list of the accidents, the size of the stool, was it effective, was it small, medium, large. All this information in daily contact with Dr. Lemon helps her to determine what program might work best for your child. If it's the arm that the child would benefit better from rectal enemas, then we will book them, which is a huge commitment, I must say. We book them for a week-long trial. They come in every day. The first day I will teach them how to do the rectal enema and give them the equipment, and then we do a daily x-ray. So the family, if they're from out of town, they'll be set up in a hotel. They go to the hotel in the morning, they wake up, they do the enema, and we start the volume of the saline based on the barium enema that was done to assess them. So if the contrast that was used was 1,000 mils, we'll start with that. So we also use the enema again to help direct where to start with the saline enema. So the parent will do the enema in the morning, come to the hospital, do an abdominal x-ray to try and look at the colon and see, well, is all the poop gone? Was that enema effective enough to clean the colon out? If not, we'll raise the volume of the saline. She may then tweak it and add some additives, as Dr. Goldstein mentioned. So by doing a daily x-ray and an enema, she can, together with the family's history, whether there was accidents, were they clean all day? Did they poop in the toilet? Did they poop in their pants? So doing the daily diary in combination with the x-ray helps sort of determine what is the best regime that works for that child, with the dream of being clean during the day, not having accidents, not having pain, feeling better, eating better, and that sort of thing. So that's the dream. So then the purpose of the program in general is really to help the child have a controlled evacuation of stool, right? So that everything's done in the morning so that they can be clean all day and go to school. At home, what that looks like then after they leave is, again, the morning enema. So this can be difficult for some families. It's just not logistically possible. So it may not be for everyone, but for the children that are able to have it done with their family, we've had some good success. So currently, Dr. Lemon mentioned today, she probably has 10 families right now that she's in contact almost daily, tweaking their programs. Because things come up such as travel, illness, their stool pattern changes, even briefly. So sometimes there needs to be that constant support, and they can also contact me if she's not available, or as a team we determine what can we do to try and improve the situation for the moment? And sometimes they'll even have to come in hospital and I'll have to do a roto-rooter rectal irrigation and basically just unplug them. Because with things like travel or starting school or in summer when they're not drinking enough water, things could change and they just get bunged up. Meanwhile, for the rest of the year, they're just fine. So we do have, an area that I can help clean them out and get back on track. So I think having that team approach, access to resources in our system, it's working pretty well. So if anyone is interested, Dr. Lamin would like to invite any families who are willing to come and entertain the idea of the bowel regime program, have a strategic approach. She would listen to you, and it's not to say that you have to be committed to something, but it's just to discuss your child's issues and what you might have as goals. What do you think you want to improve? Because as you mentioned, some children don't care. They don't care that they're wearing a diaper at the age of 5. It doesn't bother them. It bothers the parents. So it's nice to sit down in a room together to figure out, well, what is your dream? What is your goal? Because my goal might be, well, I want them to have no accidents and all this. And the mom might say, well, I'd be okay with 1 or 2. He can wear a little pad or something. So it's nice to have a team approach and figure out, well, what's your dream? What's your goal? And then how could we get there? And then just to touch on that behavioral component, and I think we have to remember, so what I like about all the newer information is that we know that most do well, many don't, and I think now we're understanding more about why that is. Because you mentioned the rectum's gone, the anus doesn't work normally, right? So the motility is different. There's that sensation. I've had school-age children tell me, I can't feel when I have to poop. I don't feel it till it's coming out. And then a year or 2 later, I know Dr. Keijzer's had a young lady, a year or 2 later she said, I can feel it now. So I think you're right. I think they somehow adjust. They learn that complex system between the anus and the brain, and they learn to figure it out and figure out their body and how it works in combination with, the diet. So I think that's great, that we need to understand, that most do well, some don't. Why don't they do well? And it's nothing that you as a parent are doing or not doing. It's because there's a lot of physiologic things that are contributing to that. And there are things that we can do to try and optimize things at the time until they can figure things out, become an adolescent and move on and hopefully not have any troubles.